So I'm joined now by Dr. Bohr, Jeff Bohr, and Jeff and I were just conversing about this whole area of exercise testing in valvular heart disease. Jeff was, in the infancy of that. Jeff, tell me, sort of give me the global view of where we stand with the concept of exercise testing in valvular heart disease.
Sure. The primary reason to interpose exercise in evaluating patients with anything is to unmask problems that wouldn't be apparent when somebody's at rest. That's most obvious in patients with coronary artery disease, in whom this kind of testing began 85 years ago.
Right.
In patients with valve disease, the use of exercise as an evaluation tool is much more recent. We began our work in the 70s. People, when they think about the use of exercise in patients with valve disease, think primarily about imaging. And of course, I've done a lot of work in that area, and I do think that that's a very good way to employ exercise. But one of the things that I think needs to be emphasized is that straightforward, formal exercise tolerance testing on a treadmill has important information to provide for evaluation of patients with various forms of valve disease. We've produced data, and others have produced data, about formal exercise treadmill testing, exercise tolerance testing, in patients with aortic stenosis, aortic regurgitation, mitral regurgitation, and to a lesser extent, mitral stenosis. The reason to do this is twofold. First, to determine the extent and severity of symptoms that are caused by the diseases. First principle of any kind of medical evaluation and treatment is you want to make people feel better, and then, if possible, live longer. To make them feel better, you have to know how badly they feel.
They often, and patients minimize their
That's
symptoms
right.
Always.
So exercise testing is very useful in that regard. Now, these days, with surgery and interventional techniques available for therapy to fix the deficient valves, it's very important to know about the presence of symptoms, because the very presence of symptoms is an indicator of a poor outcome unless something is done.
Right.
So just doing exercise tolerance testing to determine whether symptoms are present and how severe they are is very useful. In addition, the information obtained from exercise testing can be particularly helpful in prognostication, in predicting what's going to happen, so that you can determine in whom you ought to act and in whom you don't need to act just yet. That's certainly true in aortic stenosis. I should point out that many people are very concerned about exercise testing in patients with aortic stenosis because of the potential to cause sudden death with exercise. Well, my response to that is always the same. Better it should be in a laboratory when I'm standing there with a defibrillator and I can do something about it, than when the person is running down the street after a bus and nobody's there who can do anything about it. Exercise testing is very powerful in that situation. But we showed 30 years ago the prognostic value of exercise testing, even in people who already have symptoms, who have aortic regurgitation. And much more recently, we've shown just exercise tolerance in patients with mitral regurgitation who are nominally asymptomatic. The duration of exercise on a treadmill is prognostically useful. It tells us how long they're going to go without an event if they're not operated on, and it tells us how well they'll do after operation if they're tested before operation.
The AS thing is very, very, obviously is very instructive. And I think if we think about people who are asymptomatic, or say they're asymptomatic or minimally symptomatic, but tell me about the MR. That's interesting to me. I know with the AS, we know if there's a fall in blood pressure, or if they develop ischemic changes, symptomatic or otherwise. But tell me about the MR. I'm intrigued with this concept of duration alone, because I'm thinking exercise testing, see what right-sided pressures do.
Right. That would be very helpful, and there's no question that the results of exercise testing, that is the exercise tolerance deficiency that we see in patients with MR when we see it, is due to pulmonary pressure increases, no question, which can be measured during exercise, but which generally is not. Merely having somebody exercise using standard exercise testing modalities. I'll give you the numbers that we use, but they'd have to be translated for the protocols that are used in different laboratories. The Cornell protocol that we used when we began our studies had a maximum exercise. Maximum exercise was 15 minutes of exercise with increments in exercise intensity every 3 minutes. People who could exercise for 15 minutes have an outstanding long-term survival.
Is this 15 minutes on the Bruce protocol, or is it
It's a modified Bruce protocol, modified by adding one stage.
Okay, so
That's right.
So, but you're just talking. So it's like duration.
Duration is predictive. Yeah. If somebody has normal exercise tolerance despite severe mitral regurgitation, the person will do very well for a long time without operation. If, despite absence of symptoms that the patient tells you about, the patient can't go 15 minutes, can't reach that maximum, that person does substantially and significantly less well. So merely doing a standard exercise tolerance test is a way of separating out patients who will do well from those who won't do well. The same thing, it turned out, was true in aortic regurgitation years ago, when symptoms were really the only accepted basis for undertaking an operation in patients with aortic regurgitation. We looked at a number of people who had subnormal systolic function. They had echocardiographic fractional shortening that was subnormal. They were symptomatic, but minimally so, and had subnormal fractional shortening. But many of them were able to exercise to a normal extent. Those people did very well after operation. Patients who weren't able to reach normal exercise tolerance did very poorly. So there was a rather dramatic dichotomization of the population of patients who were already symptomatic, already had subnormal fractional shortening at rest. Even though they had all those findings, when we put them on a treadmill, we could determine who would do well and who wouldn't do well based on exercise tolerance.
So Jeff, sort of in conclusion, I mean, you've done some fabulous work, and I think it's very tremendously educational and informative to all of us. Should exercise testing, whether it's with or without imaging, be a key component of the workup of a patient with valvular heart disease?
In my view, Randy, exercise testing should be part of the evaluation of everybody with valve disease, and that's what we do. We routinely perform annual exercise tolerance tests in people with various forms of valve disease, in addition to the imaging, in addition to the resting echo, in addition to the other things that we do.
It's interesting because I think it's barely filtering into the practice of cardiology around this in the United States. I can't speak for Europe because I'm amazed at people who will. Here's a patient who's asymptomatic with significant AS, and we're not going to do an exercise or MR, and we don't. You know, how do I know? And so it's not there. But you know, through your work and work at meetings like this, I think the message will get out there. So very important. Thanks so much for educating me. I learned something about MR that I didn't know there, so that's good. Thank you.
Sure, my pleasure.
I'll shake your hand. Thank you. It's good.